Okay, good morning, everybody. Welcome to our Data for Brain Health and Dementia session, which is something that we're hosting as part of the SPIND network. That's Sustainable Prevention, Innovation and Involvement in Dementia. Emily, do you want to pop the slides up? And I can let everybody know that in a moment I'll be handing over to Kieran, who's going to be hosting the day for us. And we have a number of speakers. We're very delighted to have the number of speakers that we've got who represent different longitudinal data sets or examples of the use of longitudinal data sets. Emily, you all right with those slides there? Here we go. And should we pop them onto slide view as well? So we're doing this series of talks as part of helping people to prepare for submitting to our flexible fund, which has been open since January, and the closing date is the 31st of March. So all of the Dementia Network Pluses have this flexible fund. If you want more details about the requirements for the fund, then they're all available on our website, and the web address for that is at the bottom of this slide. Two of the requirements of the fund are that people consider diversity and also involve the public or patients, either people living with dementia, family carers, or people who are concerned that they're at risk of dementia within their application. But we know that that's often challenging for people who are involved in large data sets or statistical analyses. So if you're looking for further information about co-production and involvement, we have some conversation with some of our core lived experience group members and co-production partners, and you can find that information again on the website. And we've also got a video with Martin Orrell, who is the chair of the funding panels, and he's talking about some tips for writing a strong application. So those of you that aren't already signed up, do sign up through the website to be kept informed of news and events. So we've got another slide just to highlight the objectives for today, which is, so that's next slide there, Emily, where we're particularly emphasising that we're keen to have applications from people that are using large data sets or longitudinal data sets, but we do want you to also think about how to involve public and patient and to consider diversity. So that's our where we're trying to get to for the day, and I'll hand over to Kieran as your host.
Thank you, Georgina. We certainly have a wide array of different speakers today and a packed agenda. My name's Kieran Egan. I work at the University of Strathclyde. I'm one of the co-Is on the SPIND project. Please feel free to add questions in the chat. We do have time allocated later in the webinar for a discussion together that will be hosted by David Llewellyn. But what we should do now is really...
Kieran, I'm so sorry to interrupt, but just to say, we're really encouraging people to put questions in the question box rather than the chat box, because the questions, we can spotlight them on the screen, we can include them in the video, we can tick off when we've answered them. So if people have a little look at the bottom of the screen, there is a chat box, but there's also a speech bubble with a little question mark in it, which is the Q&A box. So if there are things that you want to pop in the chat, others can see that. We're not banning you from using the chat, but for questions for speakers, the Q&A box is even better.
Thank you, Georgina. So we should get going, I think, with the first presentation. We have a presentation here from Morag Henderson and Vanessa Moulton from the Centre for Longitudinal Studies. So we pass on to those slides, and then the speakers could introduce themselves. Thank you.
Thank you, Kieran, and good morning, everyone. Hi, my name is Morag Henderson. I'm based at the Centre for Longitudinal Studies, and I'm the training lead that oversees all of our cohort studies. And so it's in that capacity I'm here to speak with you today. I just want to acknowledge Vanessa, Dr. Vanessa Moulton, who's our cognition expert at CLS, study researcher and training co-lead, and she led on the preparation of the slides for today. So in the next 15 minutes, it's my aim to describe our studies, the structure and the content, focus on some relevant measures for dementia risk, show some future data collections, and point you to resources, training, and information on our studies. So this presentation really just scratches the surface, so I'm hoping it will prompt you to find out a bit more and look at the resources that I'm pointing you to today. Next slide, please. So as I'm sure you all know, longitudinal studies follow the same individual over the whole of their lives. They allow us to study sort of developmental trajectories as we can observe early exposures, including modifiable risk factors, as well as protective factors that might be observed in infancy, childhood, adolescence, and beyond, and how these things might be associated with later life outcomes. Next slide, please. So at the Centre for Longitudinal Studies, we run 4 of the main British cohort studies. These are rich, multi-dimensional, nationally representative data sets, and they essentially have built-in comparison groups because they are nationally representative. The eldest of our study were born in 1958, and then the next eldest are BCS 70, who were, as its name suggests, born in 1970. These studies might be considered to be quite young with regards to dementia research. However, I think there remains quite a lot of opportunities for research now on cognitive aging, and other opportunities will arise as they age and the data sets continue, new data collections continue. The other 2 studies are not going to be the focus of today's talk, but I'm just showing you these for future opportunities for cross-cohort analyses. Next Steps 89 and MCS, who were born around the year 2000. And the other brief study I want to mention, which is not part of CLS, but is part of UCL's suite of data sets, is the National Survey of Health and Development, the NSHD, who were born in 1946. We consider this our sister study, but it's run by a different team with different access arrangements. But our NCDS and BCS 70, the elder 2 studies, really follow the NSHD's design and follow in its footsteps. Next slide, please. So here's the study timelines for the 4 cohort studies we have at CLS. This chart shows years on the on the y-axis and age on the x. And this visualization hopefully allows you to note when each sweep of data collection occurred. So it allows you to compare across cohort and across the life course when we've collected data. So as I've mentioned, the 1958 NCDS study is the oldest of our studies, and the most recent data available is age 62 to 65. The reason it's such a long sort of period is because we started data collection during COVID, so there were some delays in field work. This year, we're collecting data age 68 on NCDS, and at the same time, we're collecting data from BCS 70, who will be age 55, 56 this year. So 2 new data collections that age into even more relevant scope for your types of research. The most recent data for BCS 70 is age 50. Next slide, please. So this slide gives an overview of the sort of structure of our longitudinal data. This is the NCDS, so it's the longest series, the most frequent, the greatest number of sweeps of data. So there are 12 sweeps in total currently available. As I've said, obviously the data is collected across the whole of the life course, and it's not just medical, but it includes both social and economic data, including things like education, income, and parenting. And the surveys are really rich and detailed. This data source is unique, as most aging surveys start at around age 50, so any data in early life in those types of studies are retrospectively captured. Here we have prospective data on our cohort members across the whole of their lives. The study started as a perinatal mortality survey to investigate factors associated with good and poor health of mothers and newly born babies, so the focus initially was medical, and because of this medical focus, there was frequent medical sweeps throughout childhood, and biomedical sweeps later in adulthood at age 44 and 62, including some blood samples to extract DNA. Just to briefly say as well, the data are linked to hospital episode statistics for those who consented, and that linked administrative data are available on secure access. And I'll say a little bit more about data availability in a moment. Next slide, please. So just to focus on a few key areas of data that might be specifically relevant for your research. So starting with cognition, just focusing on the 2 older studies here, so the 1958 and the 1970, and each cell shows the age at which the data were collected. So cognitive abilities were measured in childhood across the course of their childhood, and cognitive ability measuring cognition in childhood, as we know, is really important for cognition later in life over and above educational levels. So for NCDS cohort members that were tested at age 7, 11, and 16, and there are measures at age 11 of verbal and non-verbal reasoning, visual, spatial processing, reading ability, and maths, for example. Next slide, please. In adulthood, we capture cognitive function in both the studies, 58 and 70, and these are capturing tests of short-term memory, processing speed, executive function, and these tests have been followed up in the most recently available data, so you can start to build trajectories of cognitive function from childhood to adulthood. Next slide, please. Again, so just to show you a little bit about what might be useful for your own research, these are focusing on physical health measures that are captured in the studies. So for example, we've got BMI captured frequently across the life course for both studies, physical activity, health behaviours, as well as self-report of specific medical conditions, so things like asthma and diabetes and other long-standing illnesses. This sort of shows that you can look at time sensitivity, so you can look at BMI trajectories across the life course, as well as mental health, which is not shown on the physical health side, but there's lots of aspects that might be useful to show trajectories across the life course in relation to sort of healthy aging and cognitive aging. Also, just to mention, we've got genetic data collected and it's been genotyped, so that enables a polypoprotein to be derived, and in fact this will be derived as part of a project that I'll mention briefly later. So there's lots of opportunity to look at the sort of biomedical dimensions. Next slide, please. In addition to that, we captured anthropometrics, so physical function. So now I'm going to focus just on NCDS, but many of these measures are also captured in the BCS-70. So this slide outlines the objective measures relating to anthropometry and other physical functions. So these were captured by a nurse's visit. And during that visit, nurses captured information on, for example, waist and hip circumference, body fat, blood pressure. Vision and hearing were collected by self-report at the same time, and you can find out more about the protocols for each of these measured in the user guide. Next slide, please. As well as the anthropometry, we've also got biomarkers. As I mentioned, we captured blood samples at age 62 to 65 in the most recent sweep, but also earlier sweep at age 44 to 45. If participants consented, 5 tubes of blood were taken, 2 were used for biochemical analyses, and you can see here the types of biomarkers extracted. So just pulling out a couple: total and HDL cholesterol and C-reactive protein. And new to the study at age 62-65, we captured 3 new cardiovascular health measures: troponin I, NT-proBNP, and growth differentiation factor 15. There's a specific biomarker data set for download on end user license about this data, and the information is in the main user guide. Next slide, please. So as well as that data that's freely available for download, we also have a slightly more safeguarded data set that captures more information about metabolomics in NCDS. This has its own separate user guide and is accessed slightly differently, so I'll explain that in a moment. Serum samples were available for about 5,000 cohort members, and from those, 250 biomarkers were quantified, including that list that's mentioned here. But more details about the extraction, curation, and dataset description can be found in the user guide. Next slide, please. So just sort of wanting to flag some upcoming data collections that might be of relevance slightly longer term. So I mentioned that later this year, we've got a new data collection for age 68 NCDS and age 56 BCS-70. The new sweep will be a 50-minute web survey. It will take place in autumn this year, and it's funded by the Economic and Social Research Council. It covers 3 broad areas: the social dimensions and health dimensions there. But in addition to that, after the web survey, participants will be invited to take part in a battery of computerized cognitive tests. So there'll be 10 tests. In addition to that, some blood-based biomarkers will be extracted. I should say the sub-study is funded by Alzheimer's Research UK and the Alzheimer's Association. And the sort of design of this study follows InSight 46, which used the 1946 data cohort members. So here, this is called InSight's 5870 sub-study, and as part of the blood-based biomarkers, we'll extract the amyloid beta and the tau protein, as well as genetic data. And the design of this follows that 1946 InSight study. they've currently started to use brain imaging and PET scans, and something that we hope to replicate in the future, but currently don't have funding for. Next slide, please. So I should say all of these slides will be available afterwards, and this is just a list of the 10 cognitive tests that will be included in the Insight 5870. So that data collection, as I mentioned, will start in autumn this year. Next slide, please. So just a brief bit about accessing the data. I've sort of alluded to this a bit before, but next slide, please. But all of the data are free of charge and available to download in the main from, next slide, please, the UK Data Service, which is an archive of all of our data. All you need to do is have a university account and register and log in. The data have different categories. So the least disclosive is you can just download it immediately with a short project description. As it becomes more moderately or sensitive or disclosive, then it requires a little bit more detail in your application, but it's not super onerous. So the special license, the data is still available to download, and it's only on the very secure data that you'd have to use a trusted research environment to access it. Next slide, please. So where to go for more information? CLS website is the main one. Each study has its own page and a description of the sweeps. Next slide. There's lots of documentation, user guides, technical reports and questionnaires. Next slide, please. We have a really active training and support page that flags up lots of different methodological, specialized data and thematic data. And next slide. And all of those recordings and webinars that we've done in the past are featured on the CLS YouTube channel. So you can look back and look at those recordings. Next slide, please. The next slide. So this is just a screen grab from the types of things we include. Oh, sorry, if you go back to the YouTube channel. So it's got scientific content specialist data, methodological data, and all of those are available as a sort of reference for you to look at. Next slide, please. Yeah, thank you. This is, I was asked particularly to mention user engagement and diversity. So I was going to keep this for the discussion, but if we've got time to talk briefly about it now. So we don't do patient and public involvement necessarily in the same way that healthcare does, because our participants, our cohort members, are essentially our main the people that we engage with. So we need to make sure that they're retained in the study. So we do that through news mailings, contact tracing, birthday cards, updates on research from our studies. So that's ongoing. In terms of data users, we do a lot of outreach work to make sure that we're getting advice on consultations about the measures that we include in our study. So for every data sweep, we go to the wider research community, do online and in-person events to get information about what the sort of steer of our studies should be. We also have a scientific advisory network where we cover different scientific themes relevant to this conversation, our cognition and aging. We currently have around 140 members, and we do regularly refresh our network. So I've just included the email address. If you're interested in following for any news about our studies, then sign up to our newsletter. The last point was that I was asked to say a little bit about diversity in the cohort studies. So the younger two are very diverse. They're oversampled in terms of ethnic minority and social disadvantage. And that's really a product of the time that they were started. If you imagine back in the 1960s and 50s, when they were developing BCS and NCDS, the society was much less ethnically diverse at the time, and perhaps there were other sort of biases going through that. But the design of that study was, it was children born in one particular week in the Great Britain. And so it means that we don't necessarily capture migrants particularly well in the birth cohort studies because they are longitudinal, and because BCS and NCDS of its time, there's only around sort of 300 to 400 in each of the studies from an ethnic minority background. But we do work hard to make sure that it's representative of the period at which the birth cohort study started. So I think that's everything from me, and I can say thank you for your attention.
Thank you very much, Morag, for such a comprehensive overview there, and also for keeping to time. It's brilliant.
And the next slide does have the contact details on as well.
Yeah. So I would encourage folks to reach out using the contact details here. As a reminder, Morag said it there as well, this meeting is being recorded. It's going to be hosted on the Dementia Researcher website. We'll also have it up on the SPIN-D website, so appreciate there's lots of details here. I wondered, we will have time for questions, discussion later in this webinar. I wondered, Morag, is there anything specific you'd love to see from SPIN-D applications for this funding call that's happening just now? It seems like there's huge opportunity, different data sets, new waves, collection waves. I was wondering, anything top level that you'd love to see coming from it in terms of applications or next steps from the dementia community?
I think cognitive aging would be really interesting to track over the life course. I think we would support any application using our data, because I think there's such richness there. There's almost too much to isolate to one single project. But yeah, we'd just encourage some good creative scientific thinking about and using the data that we have available across the medical, social and economic dimensions.
Thank you very much, Morag. Fantastic. I think we should keep going. And as I say, plenty of time for discussion later. Our next speaker to introduce is from the Dementia Platform UK and is Emma Squires. So we should have our slides here ready to go. So I'll pass across to you. Thank you, Emma. And I'll let you carry on.
Wonderful, thank you very much. I'm the Chief Operating Officer at Dementia's Platform UK Data Portal, so I manage all the data applications and make sure all the data comes in and is available for researchers to apply to use. I'm just going to give a real quick whistle-stop tour of the discovery tools that we have and how to explore the data holders within Dementia Platform UK, and also talk about where to get started and how to explore these really diverse data sets. Next slide. So the DPK has been running for about 10 years now. It's a very mature platform. It is a fully trusted research environment. The data that we hold is quite sensitive data. They've been consented for onward sharing, but we keep privacy and make sure that that data set is anonymized when it reaches the researchers. They have over 50 population and clinical cohort studies on the platform, and these comprise over 3.5 million people. There's 107 data sets that make up these. We have a lot of multimodal data sets, so a lot of genomic data and imaging data that have been collected. So we really do have quite rich data sets for research. We've processed over 750 project applications, and these come in from all over the world. Because we're a trusted research environment, researchers come into the environment, therefore they're using the data. The data's hosted in Swansea University, that's where I'm from, and the data's hosted there, so the data is only ever accessed there. It makes it a really great platform to be able to allow global collaborations. Next slide, please. So this is just a quick slide for trusted research environments. For people who may not have used trusted research environments before, they're great environments because they allow sensitive data to be analysed freely where they wouldn't be able to be released into the public. So what happens is data's brought in, we bring in the raw data, we anonymise that data to make sure that we've taken away any identifiable information on the participants, and we allow researchers to access that data via a virtual desktop. Well, they've got to apply, they get approved, and then the approved researchers are able to access that data via a virtual desktop. When the researcher gets access, then they can analyse the data, and when they have results, they can apply to take the results out of the environment, but the data never leaves. I think the other thing to say about trusted research environments is we follow the 5 safes framework. So for researchers, that really means that you need to be a part of an academic organisation or an industry organisation, but we need to know that as you come in. And that you need to have a supervisor and you need to have a sound analysis plan. to be able to access the data. But the platform itself is free at the point of use. We have funding to be able to allow that. And it means that we're able to provide researchers with the standard desktop and access to phenotypic data. When we get into the more complicated imaging genomics data, they require lots of storage. And also if we're looking at having large compute, that could also be looked at on a cost recovery basis. Next slide, please. So the computational resources that are provided, we provide Windows and Linux desktops for data analysis, and these are all preloaded with software that you would hope to see as a researcher. Python, R, Jupyter, Anaconda, they're all available as standards. They don't require additional licenses. Next slide, please. So what we've invested really heavily in, as we've got, all these cohort data sets, is data discovery. If you've got 107 data sets, we need to be able to make sure that researchers can find the data that they need for the research that they want to carry out. Nothing worse than applying for data, getting it, and none of the questions that you were interested in was actually completed. It wastes everybody's time. So these are the discovery tools that we've got on our website at the moment. The first level is a cohort matrix. And what that shows is all the cohorts that are in the Dementia Platform UK, and then some very high level details about those data sets. And we use the CSERV ontology to categorize data for data discovery. So we group variables into sensible categories such as administration, sociodemographic, medical history. We also grouped omics data so that we know what types that we've got. So this is nice just to get a real snapshot view of what data is held. Next slide, please. We can then dive deeper into these data sets. So from that tool, if you clicked on Airwave, you would come through to one of our first data sets, the Airwave Health Monitoring Study. And then you can see that you get deeper into that data set. So you've got the study overview, you've got information about that study, when it was collected, if there's follow-up, those high-level details. And then we can really drill down into the data set and look at the variables that are available inside that data set, so you can get a real good understanding of whether the information that you wanted is collected. Next slide, please. We've also developed a feasibility is a problem here as well. You could have age, but have you got the specific age range you need, or the specific BMI range that you need for your study? That's hard to know from standard data discovery tools. So we have this deeper dive cohort explorer that allows you to filter our top, I think it's 15 data sets, to find out across those data sets what does the demographics of these participants look like, so that you can get a really good understanding of whether this data set is going to provide the participants that you need for your study. Next slide, please. We also collect a lot of imaging data, and we pre-process that imaging data for researchers. All our imaging data, once collected, is put into BIDS format so that it's ready to go. And we've invested heavily in imaging pipelines to generate image-derived phenotypes from that data set, so reduce the barriers for researchers to come in and have measures like brain volume as standard inside that data set, because actually having the compute, the storage and the skill set to analyze raw imaging is quite a barrier to being able to include the results of those measures into your research. So we've invested a lot in being able to do that. So a lot of our imaging data has image-derived phenotypes available for them as well. This is slightly out of date. That last column on there has got a few more in, but I'll explain why it's outdated near the end. And as you can see, what we've done is we've categorized those images as well in another snapshot, so that you can see which data sets have got structural MRIs and functional MRIs, diffusion MRIs, MEG data. We've got some MEG data in the portal, and also PET imaging data as well. So it's great. And obviously a lot of all of these cohorts will have phenotypic data associated with them as well. So we can link the imaging data to the phenotypic and in many cases the genomic data. So there's a real nice rich data sets. Next page, please. So this again is the genomics matrix. So for the cohorts that we hold genomic data on, we've also got this nice snapshot that shows what type of genomic data has been collected for these studies. And as you see, you can most of them we've got VCFs, or we're able to acquire VCFs, and we've also got ApoEase data for a lot of them as well. And we've collected quite a lot of GWAS data into the portal to allow analysis as well. Where we've got a flag, it normally means that we can get that data on a project-specific basis from the cohort themselves. So we're able to negotiate with them to be able to get the data that you need for your study. Next page, please. We've also done a lot of work with Cardiff University and UK DRI on making data available that's associated with stem cells. So the IPMA study, I think it's about 60 stem cells have been generated for research, which can be applied for the actual stem cells. But the data associated with those stem cells and the phenotypic data about the participants that these stem cells were generated from are being hosted inside Dementia's Platform UK. So this is another area that we've invested in. Next page, please. So application process. If you go and have a look at our discovery tools and that you see the data that you want to be able to do your study, the first step would be to submit an application through our website. And then it'll go through multiple stages of approval. The first is we do a check that makes sure that the study is sound, that you're not asking to do a study on data that we do not have, just a sanity check on that application. If there is an AI or ML component to the project, that triggers a whole other form, because we need to assess that there is no privacy risk from release of the AI model at the end. If you want to keep the AI model in and you're not looking to release it, that's a much easier process. But releasing AI models, they can be open to being regenerating the data, and that creates a privacy risk that's we do not permit. So we look for mitigation strategies, and you have to justify how you're going to reduce the privacy risk. We also then go to a technical triage to make sure that you've got the compute that you need to do your study. If you're asking to do a whole AI model project with a standard desktop, we have a little chat and check that it's not going to take 4.5 months tanking one poor computer. So we check that the technical requests are appropriate. If there's commercial elements to your project, if you've got commercial partners, then that needs to be assessed to make sure that the project would be in the public good. So we have a panel that would assess that application and make sure that and give its recommendation to the data providers that this is actually in the public benefit. And then it goes to the data provider. So a lot of the data that we hold, the majority of the data we hold in Deep UK, we are processors. The data providers remain controllers. So that application goes to them after we've checked it all. So we don't want to give them lots of applications that are going to fail. They then give their final approval. And if it's approved, a data access agreement is signed by the researchers. And then they are provided with access to the portal where they can come in and do their analysis using the tools and software that I've already mentioned. Next slide, please. So getting started, we've tried to invest in giving people information about working in a trusted research environment, because for a lot of people, this is new and something that is helpful, even when you're planning an application, to have a look and understanding of what's involved in working in a trusted research environment. So we have some courses on a platform called DataSize, and I put the link in here. The thing. One is very good. The first one, the introduction, is really good before you submit an application. And once you've been approved, the second one is really handy for getting an idea of the environment you're working in, where the data's stored, how to set up your Python environment, those kind of things. So they're really helpful. If you're planning on doing AI Like I said, it becomes more complicated. We have to ask lots more questions, and it is really worth undertaking a course that my colleague Lewis Hotchkiss put together around AI privacy and the mitigations that you can put in to ensure privacy in those AI models. All these courses are free, so they are definitely worth having a look at. I would also recommend getting safe researcher training from ONS. I think there's another one as well. These are really good courses to be able to demonstrate to any trusted research environment that you want to work in that you are a safe researcher. Next slide, please. There's also a lot of training and mentoring. So on our main Deep UK website, there's datathons and there's academies that run by my colleague Sarah Baumeister. These are fantastic. They go from early career researchers and they build you as you go, so from beginner into intermediate into advanced level analysis. So it's worth keeping an eye on that website for those opportunities that come up as well. Next slide, please. So as part of this and the request to present today, there was questions around the data limitations, and I think for DP UK, these are legacy cohorts. Some of our data sets are ongoing collections, but for the majority, they've been inherited. The limitations very broadly are we're going to have geographic limitations on them. So a lot of these studies are from Oxford, Cambridge, London, the major research sites. So geographically, there's a bias there anyway. They tend to be more around urban populations rather than rural, and they tend to be within areas with academic hospital networks and specialist research clinics. So that needs to be taken into account when using these kinds of data sets. Also, demographic representation, as the previous speaker mentioned, these new collections, you can build that in, you can start with what you've got, but the older collections, they wouldn't have been in there. So they will be predominantly white, more highly educated people, they're from higher social economic backgrounds. So they will be inherent bias into these older studies, but we are working with new collections to make sure that this is addressed going forward. Cohort studies design. A lot of the cohort studies that we have on our platform were set up to answer a specific question, and onward sharing is a secondary activity. So the protocols will vary. There could be variables that are missing. They weren't designed for this very wide research. They have particular thing, and this is why the data discovery tools are really important. And so the data discovery tools I've shown you are what's coming on our website. We are literally, probably the end of next week, about to launch our new discovery tools, where you can compare cohorts, you can see what the overlap between different cohorts are for the variables you want, and there's an AI search engine that will allow you to look for, say, diabetes or whatever it is you want to look for, and it will pick out all the cohorts with data that's in there. I'd like to share that in the chat if that's okay with the organisers. It's a beta version. It has not gone live. Don't be creating baskets. But for researchers really interested in using data across a selection of cohorts, there's some fantastic features that allow you to compare that. So I'll pop that in the chat in a moment. Next slide, please. And there's a few more limitations here as well. There's healthy volunteer bias. A lot of this, the longitudinal studies will be healthy volunteers that will eventually develop dementia for a lot of them. So the data may be missing at these points in time. It will come longer on. And there's also a historical focus on research questions, as I said, to answer those specific hypotheses. And I think these are really the big areas to think about if you're doing research using these kinds of data sets. And there's ways of mitigating those. Next slide, please. So what we have been focusing on doing is expand into international multimodal data sets. So we've brought in the RADC data sets from the UK, from America. There's a lot of ethnic minority data sets in there, which are helpful to include into other studies to increase that diversity. We've also got a large study from across France called Memento, which is a wonderful study. So you can go and have a look at that one as well. So where we can increase our geographical locations, the more diverse that data sets become. So we've been pushing in those areas. Integrating the population scale data. So those new collections that were talked about previously, they're the kind of data that we want to be able to link with in the future to expand the data that we've got and to improve on those data sets. What I did mention is if you've got access to a project, you're also able to bring in data. So for those data sets that were mentioned that you could download and you could bring them into the research environment of Deep UK to combine with other data sets as well. So that's a good way of addressing the diversity issue. We also use CSERV to harmonise our frameworks, so allow that cross-cohort comparability. So if you can use 50 data sets, the chances of increasing the diversity in the sample that you're studying is going to increase. And the new tool I'm going to share is really good for being able to do that. We also try to advise new cohort collections on diversity and things to include in that. My colleague Sarah Baumeister has done an awful lot on including minority groups into data collections. But my personal interest is in data federation. So even as we're talking today, we're talking about data collections that are locked down in different places to, if you wanted to use the data from each of those TREs, you would have to submit multiple things and work inside those TREs. Federation would allow a researcher to be able to, from one place, access multiple endpoints. This is really important, especially when you've got small numbers, rare diseases, or you haven't got the great numbers in any one collection. Being able to federate out to different endpoints will be game-changing for that type of research. That's it. I think that's my last slide. I'll hand back to the host. Thank you.
Thank you very much, Emma. That's a huge volume of data and lots of detail there. So I'm sure of huge interest to folks on our call today. There's two quick questions here in the Q&A that I thought might be worth addressing just now, and then there will be time. I know there's other questions there. We can come back as a group and go into the discussion later. So Rachel Allen is asking, can the links to the training please be added to the chat? So we'll see if we can facilitate that. And then there's an anonymous question here saying, can a master's psychology graduate do the DPUK courses and join the mentoring program, even if not linked to an academic institution for the moment?
Yes. So what we would ask for anybody who is not linked to an academic institution at the moment is if you've got somebody who is academic that can just vouch that you are in the research areas. So we have this a lot for the training courses. We have people that are currently between jobs. As long as we've got a reference from an academic institution, then we will allow that. That's fine.
Thank you very much, Emma. Thanks for the presentation there. I think for in the interest of time, we'll go straight on to the next presentation. And as I say, conversation space certainly coming up later. So delighted to introduce Laura Gray, who's going to be talking to us about patient public involvement in statistical research, top tips for meaningful involvement. So over to you, Laura, and thank you for supporting the call today. Thanks.
Thank you. Thanks for having me. Hi, everyone. Yes, I'm really pleased to be talking about one of my favourite subjects, which is patient and public involvement, and sharing some things that have helped me along the way, which might also help you. So next slide, please. So I hope you all know what I'm talking about when I mention the acronym PPI, patient and public involvement, but just to make sure we're all on the same page. This is research with or by members of the public or patients, rather than to, about, or for. So we're not thinking here about including patients as participants in studies. Here we're thinking about including members of the public or patients as active members of the research team who are shaping the research that you're going to be doing. Next slide, please. So PPI is well embedded into applied health research, but it's less well embedded into other forms of research, which might seem a step removed from direct patient benefit. So, for example, I work in statistical methodology research, and have really struggled to include PPI in the work that I do, and that has sort of led to a whole journey and research program into looking at how we can do a better job for these types of studies, which are a step removed, which I'd include sort of database research within that. So I have a lot of experience now of doing PPI for methodological research and for sort of database research. I don't have direct experience of doing PPI for dementia research, which I'm sure comes with its own challenges, but I'm going to focus today on the sort of methodological aspects. Next slide, please. So just to say, we are doing some work in this area. So we've recently been doing a targeted review looking at how much patient and public involvement happens in secondary data analysis projects. So we've been reviewing papers that have been submitted to the BMJ because they have a mandatory PPI section that has to be completed. And while this work isn't published yet, I'll give you a spoiler, which is that not many papers that undertake secondary data analysis using existing databases are conducting PPI, which is a real missed opportunity. Quite often the reasons they give is that we're not recruiting patients and therefore we haven't done any PPI. And I would say there's so many places that patients and members of the public can get involved in secondary data analysis, thinking about which covariates to adjust for, thinking about who to include in analysis, which outcomes are important. It really is a missed opportunity. Next slide, please. This is just another example which showed, sadly, similar results. So this study conducted by 2 of our PhD students looked at patient and public involvement in prognostic modelling papers, and these quite often use existing data sets. And they looked at 6 clinical areas. And of all the studies that they reviewed, none of them had reported doing any PPI, which again is really sad because a prognostic model hopefully will be used in clinical practice to improve outcomes for patients. So these do have a direct relevance to patients and members of the public. Next slide, please. So I'm going to share with you some of my top tips. And I guess my biggest top tip that I want to start with is to prepare. So quite often PPI is new to researchers who work in secondary data analysis, statisticians. Quite often it's not something that we're used to doing ourselves. So the more preparation you can do, the better. I would also say that quite often it's new to the public contributors that you're working with as well. So making sure that they understand how this research is different to maybe the types of research they've been involved in before, and making sure they feel empowered to be involved and to make a difference to your research is really important. So I'm going to go through some resources that might help you to prepare, but can also be used to help your public contributors prepare to be involved as well. Next slide, please. So the first thing I wanted to mention is there's a growing body of research literature on how to do good PPI for these topics that are a step removed from direct patient benefit. And there's quite a lot of research in the area of big data and secondary data analysis. So you can see one example on the slide here. So I would really recommend looking at that literature and being informed by it. Like this paper here is really useful sort of recommendations around including people. And I think that's a really good starting place to make yourself feel a bit more confident before you get going. Next slide, please. So we've had great success with using the People in Research website to recruit patients and members of the public to get involved in our research. I think quite often people assume that members of the public won't be interested in methodological research or secondary data analysis type research, but that's not been my experience. One top tip I would give is to ask for expressions of interest and then have a quick Teams call with those people that have come forward that you're interested in recruiting to your PPI group. In my experience, that's been really useful to make sure they understand how your research is maybe different from the other research projects they've been involved in. And it makes sure that they're right for your project, but also that you're right for them and that they understand and are keen to get involved with the type of research that you're going to be doing. So I would say that's a really useful thing to do. It takes a bit more time, but I always think the more time you can put into public involvement, the better outcomes that you get from it. And I think having an initial informal chat with people before you recruit them to a PPI group can be really helpful. Next slide, please. So there's lots of organisations now that can help you. So a few are on the slide here. So you can see PEDRI, which is Public Engagement in Data Research Initiative. They have a resources page on their website, which is full of things, blogs, animations, lots of resources that you can use within your PPI. One thing that we've found really helpful is we made an animation which describes in an accessible way what statistical methodology research is and why PPI is important to this type of research. And we always send that to members of the public before our meetings so that they can orientate themselves and know a little bit about the type of research that they're going to be involved in. But you can also see on the screen DataMine, that's around secondary data analysis in a mental health space. There's HDR UK and there's Understanding Patient Data. So have a look at these websites, see what resources exist already that you can use to help you do a better job of PPI. Next slide, please. There's lots of case studies now as well on the website. So you can see here, Animated Me. We've developed on our website a number of short animations which are for public contributors to understand a bit more about how members of the public have made a difference to our methodological research. And then alongside them, we've got sort of fact sheets that are more for researchers. They go into the sort of nuts and bolts of how we went about the PPI and what we felt worked well. Another example on the slide is Ruth Jack at the University of Nottingham. She's developed some quite nice case studies around her work using primary care data and getting patients involved in that. And all the links are on the slides, and you can have the slides afterwards to access these and have a look and see if they might be helpful for you. Next slide, please. A number of glossaries have also been developed. So the NIHR has a glossary, but it includes quite generic research terms. And actually, when you're working with existing data sources, there might be other terms that are important to use. So PEDRI, for example, they have a glossary of terms that has more data-based terms. So data governance, data linkage, you can see on the screen there. We've also developed our own glossary for statistical methodology research that includes more statistical terms. So I think these can be really helpful to members of the public to provide them with links to these so they can sort of orientate themselves ahead of the meeting. Next slide, please. So something you can do to help yourself feel more prepared and more confident is just to take up any opportunities for engagement. So you can see on the slide here some photos from some engagement activities we've been doing in Leicester. We go out to existing community groups We take a craft activity with us. You can see some iris folding going on the slides, and we get chatting to people. And it just builds your confidence with talking about what you do in your research in an accessible way. This isn't about getting public involvement in our research. It's more about highlighting the work we do and how members of the public could get involved if they were interested. But it definitely helps with your communication skills. I think sometimes I'm a statistician, I sit at my computer, I don't come across members of the public or patients all the time in my work, and they can become a sort of mythical being that, you know, you can grow great anxiety about going to talk to members of the public about your work. So I think anything you can do to get yourself out there and get talking to people is really helpful. Next slide, please. So I could talk for a very long time about PPI, but I've only got a short time today. So these are my other top tips. So I think in my experience, I only did PPI when I was applying for a grant application that meant I had to do it, which is really bad because that's already a very anxious time. And then you throw in doing PPI that you're not used to doing. Of course, it's going to feel difficult and challenging. I think changing the culture of the way we work, making PPI part of our day job, is a much better way to go about it. It removes the mystique and it just becomes something that you do. There's lots of existing infrastructure and PPI groups that can help. I showed some organisations earlier on the screen, but I'm sure within all your institutions, you know, there are people that can help you, PPI coordinators, people who have lots of experience in this area. I'd say never go to a meeting alone. It's really helpful to have someone there that could maybe chair the meeting, be the note taker, or just be there for moral support. We recently had some training in our department on facilitation skills. That was really useful because as statisticians, it's not something that we have in our sort of toolkit. If you're a qualitative researcher, dealing with focus groups and facilitating a group of people is something that's sort of built into the research you do, but it's not for us. So I think trying to seek out opportunities to get training is really helpful. And one way you can do that is to try and shadow other meetings, just to see how people run them, how they go, even if it's not about secondary data analysis, even if it's about a clinical trial. It can just be really helpful to see how the meeting's set up, how the facilitation works, how they end the meeting, those types of things. I've already talked about outreach opportunities, and I've really enjoyed, the more PPI I do, the more creative kind of ways we use to get people to be able to contribute to our research. And actually, I've really enjoyed that side of PPI. I didn't do a lot of cutting and sticking in my day job before we started the crafting activities, and I really enjoyed getting involved in those more creative elements. And I think my last tip is I used to really panic and think, well, I don't know how a member of the public could help with this research. I don't know how they could get involved. And actually, someone in one of our PPI groups said to me, Laura, that's not your problem. What you need to do is be able to explain your research in a way we can understand, and we'll tell you how we can get involved and how we can contribute. And that was really powerful to me because that was something I really panicked about because I didn't want to do something that was tokenistic. So hopefully that can help you too. Next slide, please. And I just wanted to plug, we have a community of practice for PPI for statisticians, which we run through a LinkedIn page, but we have a seminar series. You can see last year's seminars on the screen. All the recordings are available on the LinkedIn page, and there's a new seminar series for this year. So if PPI is something you're going to be doing more of and you want to share practice, get tips from other people, I'd recommend joining our community of practice. Next slide, please. And this is my last slide. Sadly, I can't stay for the discussion at the end, but I'm always happy for people to reach out if you've got any questions, or if you can put them in the Q&A function. I will answer them later after the event. So thank you.
Thank you very much, Laura. That's really interesting talk, and yeah, quite striking to see the lack of PPI involvement that you had in your review. There's a single question here that's come in, which we can ask in a time that we have, and I would encourage folks to reach out to Laura directly. Just she's saying now that she can't join the discussion later, so that's the email on the screen. So the questions come in anonymously, but it's to Laura. How has PPI helped your projects within secondary data research? Have you ever felt that PPI input deviated from what you're interested in doing for your research or research question, and how do you balance that? So I don't know if you've got any reflections for the call this morning.
Well, I think the first thing I would say, sometimes I know in my research group, people panic that anything that is suggested by a public contributor, you have to take forward. Well, actually, if they're a member of your research team, like anyone else, there's always going to be parameters, you know, things that you can change and you can take on board and that makes your research better, and things that it's just not practical or feasible to take on board. And I think we have to treat public members like we would treat any other member of the research team and be open and honest about those things. I think if there's a justification why you've not been able to take something on board, people are fine with that. But what I've tended to find is I can't guess what's going to come out of a PPI meeting before I hold one. And what members of the public are really good at doing is testing you. There's nothing like having to explain your project in an accessible way to make sure that you really understand what you're doing. But also they pick up on blind spots that me as a statistician would never have thought of. So I would say go in open-minded, be honest and realistic about what is possible and what isn't possible within the type of research that you're doing. But I think generally people are surprised by how useful PPI meetings are and what they bring and add to their project. So yeah, I would have a go. I would urge people to get involved, and hopefully their research will benefit from that involvement.
Thank you, Laura. That's a great answer and very clear. There's compromise and opportunity for everyone there. I wonder, it might be an idea just to kind of pause for a second here and just pass across to, I know Christine Wise is on the call and is part of our core lived experience group for SPIN-D. I wondered whether at this point, Christine, you might have any reflections from your own experience around patient public involvement, whether through SPIN-D or other contexts that you'd want to share at this point, or we can also come back in the discussion later.
Yeah, I think Laura's covered a lot of the points that I would want to say. I was involved in looking at the bids last year, and it was very obvious that some of them had fantastic projects, and then they obviously got to the bit that said, and how have you co-designed this? And they thought, oh, shoot, I'm going to chat through the questions with them and then give them the results at the end. Fail, you're not getting any points in that box. And there was too much of the doing to people. This is what I have decided to research, and you are going to be delighted with it when I've finished. And it was more obvious those that had engaged with the community and were researching what the community needed, wanted. Some of those questions needed tweaking a little bit, Were you researching what you wanted to, or what was actually needed? I've engaged in research as a carer. I was a carer for my late husband. My husband engaged in a lot of research during his dementia journey. He was totally dedicated to it, and his point was, they will never find a cure in my lifetime, but I might be the piece of data that leaves one behind for my children. So you need to remember what these people have got invested in this process, and respect that as well as use that. And don't assume just because they have dementia that they can't use an online forum. My husband did a lot of research, answering questions, engaging in things through online fora, because travel became difficult. So that often if the meeting was in London, we would attend online. He was a member of many online groups. So don't make assumptions that all of these groups have to be in your own backyard, which can be particularly important if you're trying to pull together groups. Trevor had a rare dementia, so one or two of the research projects were linked to his rare dementia. He was the only one in Rutland. You weren't going to bump into many others, so it had to be national and online. So to add to Laura's, hers were lovely face-to-face groups, but don't forget what facilities online can give you. But do please genuinely involve people. Don't just tag on, this is a lovely project, from somebody with dementia on the end of something you always intended doing anyway.
Thank you very much, Christine. That's a tremendous addition, and just that experience about trust and community and engagement. And I think that's really helpful for folks who are considering future applications. We should have time to continue those kind of conversations later, but really thank you. And thanks also to Laura for the PPI talk there. I'll pass across now to Isabel Foote, who's able to talk to us about the Demon Network, and hopefully we can get the slides up there. Thanks.
Thanks, Kieran. Yeah, hi everyone. And thanks to Spindy for the invitation to come talk today. I'm Izzy, and I'm a lecturer at Queen Mary University of London. But today I'm going to be talking about the Demon Network and how it can support data science for brain health and dementia. Next slide, please, Emily. So the Deep Dementia Phenotyping Network, also known shorthand as the Demon Network, is an international platform for bringing together people working on driving innovation in using data science and AI for dementia and brain health research. And our members include people from a broad range of sectors, including academia, industry, policy, charities, and clinicians across all career levels. So we have members from PhD students up to CEOs of startups. And there's currently 6 active working groups that cover genetics and omics, applied models and digital health, drug discovery and trial optimization, biomarkers, imaging and prevention. And we all meet monthly to host talks and run collaborative publications and other initiatives. We also have various special interest groups for more interdisciplinary themes, such as frailty, generative AI, natural language processing, and reproducibility in open science. And these have more focus on broad collaborative projects or running training events such as hackathons and early career researcher workshops. Next slide, please. So our membership across the network amounts to just over 1,600 members, and these come from 62 countries across 6 continents. And we have regional leads to try and help improve inclusion and reach globally. Next slide, please. One of the network's first major outputs was an open access special issue on AI that was published in Alzheimer's and Dementia, where each of the working groups produced a review of the state of the science for applying AI in each respective dementia research field. And this endeavour included around 90 international co-authors across 8 linked papers. Next slide, please. One of the working groups that's most closely aligned to the SPIN-D network is the Prevention Working Group, and that's co-led by myself and Sinew Tai at Oxford. We've got 500 international members, many of whom are highly active within our group. And these members span multiple sectors, 6 continents and career levels. And so this provides an incredibly enriching environment for collaboration. We host monthly virtual meetings every third Thursday, where we alternate between informal seminars where a speaker gives a talk for about 40 minutes and leaves around 20 minutes for in-depth group discussions. And in other months, we have brainstorming sessions where we plan or advance collaborative projects. And this ensures that members can get many chances to be involved in presenting their own work for informal feedback, or participating in collaborative projects, which helps to advance their career. And we also strongly support members to lead their own projects to ensure the group can adapt to current member interests and work to everyone's advantage, rather than being solely driven by the leadership team. And in addition to papers, we also host various other events, such as satellite meetings and networking events at relevant conferences and training workshops for the wider community that normally happen online. I would say that one of the key strengths of the network is to act as a catalyst for the community, because it provides early career researchers with a very flexible framework upon which to build their careers. And it's something that multiple PIs in the group now use as a key way of training their own students and postdocs. Next slide, please. So to give an example of such a case, I actually want to provide my own experience of how the network really helped build my research career. So as a member of the Demon community, I was invited to attend a workshop on frailty and dementia in Canada in June 2022, where I met global leaders in frailty research, which is a field that was completely new to me. And at this meeting, I voiced the idea that running a multivariate genome-wide association study of frailty might be a better way to discover a frailty risk variance compared to the traditional aggregate methods that had been used so far. Unfortunately, there were several attendees who thought that this was an interesting idea. And so with the support of my postdoc advisor, we worked on the GWAS as a sort of side hustle for my postdoc. And as part of this project, we involved Demon members from Australia, Canada, and the UK, and they provided access to relevant external longitudinal datasets, including ELSA, the Lothian birth cohorts based in Edinburgh, and the prospective imaging study of ageing that's based in Brisbane, Australia, which we used to validate our findings, and the paper was published in Nature Genetics last summer. But most crucially for my own research career, this work acted as a pilot for my current Wellcome Trust Fellowship and supported promotion as a lecturer at Queen Mary. Next slide, please. And this is just one example of where the network has directly provided sustained career support to an early career researcher. And there's many other colleagues within the group who can provide similar stories, which is evidenced by our strong research output. So in the past year alone, we've published multiple collaborative studies within our working group in high impact journals, including Brain, JAMA Neurology and Nature Reviews Neurology. And these studies were all led by PhD students and postdocs across a variety of topics, including Mendelian randomization studies, so more genetics focus, versus longitudinal trajectory modeling in UK and US based aging cohorts that the members had access to. We also have a lot of successful partnerships with other groups within the wider community. For example, members of Demon participated in a collaborative Delphi consensus on priorities for Dementia Risk Reduction Policy, which was led by the NIHR Policy Research Unit for Dementia and Neurodegeneration, alongside other key leaders in the field, including SPIN-D. Next slide, please. We have various ongoing activities within our working group that our members are involved in. For example, we're currently writing a primer paper for assessing whether a risk factor is causal for dementia, and this is co-authored by over 50 working group members from 15 countries. One of our postdoc members, Daria Jensen, who's based at the Max Planck Institute in Germany, is leading a review on AI algorithms that are being used to combine multimodal data for personalized brain health, and our idea is to develop some guidelines on practical tips for future studies. We're also organising a 2-day summit happening in Oxford in March and an international Delphi consensus on the future of brain health services in partnership with the Brain Health Coalition UK, which is in line with one of our key network themes over the coming few years. Next slide, please. In addition to the wider working group, there's also opportunities for more specialised interest groups to form. So, for example, Anouk, who is one of our postdoc members from Luxembourg, set up a subgroup of researchers who are all interested in the social determinants of dementia. And Anouk and Seb co-led a very successful scoping review of social determinants for dementia, which was published in Alzheimer's and Dementia last year, and highlighted key evidence gaps in the literature. Next slide, please. This led to the group organising a satellite meeting as part of the AR UK conference that happened in Manchester last week, where we invited attendees to participate in roundtable discussions spanning topics such as co-creation, women's health, nutrition, early life factors, and genetics as key areas for future work on social determinants research. And this has acted as a springboard for future projects for the group, and I'm really excited to see where this leads over the coming months. Next slide, please. So I hope I've been able to give you some insights into our network and how it can help support career development, data sharing and collaboration within the field. And I want to highlight this open to anyone. So if anyone here today is interested in becoming involved, or you know of anyone who might be, please do reach out and join us. We're actually currently updating our website, and that's going to be live soon. And once that's live, we'll share it on the Dementia Research platform. So there'll be a lot more information available to people who might be interested, and a joining link there as well. So please do keep an eye out for that as well. And then I just want to say thanks again.
Thank you very much, Izzy, for a really clear presentation, and I'm sure folks online will be keen to get in touch there, particularly looking at the outputs of all the collaborations there. It was fantastic. We should pass on to our next speaker, just in the interest of time here, which I can see on our slide deck is InflAIM and Charlotte Davies. So pass across to you, Charlotte. Thank you.
Thank you. Oh, just get my camera back on. Sorry, for some reason I thought there was someone before, so I'll just get myself sorted out, but thanks. Yeah. Okay, so ready for the slides?
Sorry, can I just intervene? I think actually Louise was going to talk without slides, which is why there's no slides.
Okay.
Sorry. Thank you, Emily.
Good morning. Can I check that you can see my screen? Can you? Sorry, I missed that. Yeah, you can. Okay, great.
Yeah.
So good morning and thank you for the invitation. My name is Louise Arsenault and I created and developed the Atlas of Longitudinal Datasets. So this presentation would be slightly different to the other ones that we've heard already today. I think I will trying to kind of remove that so that you can see all of my screen. So the Atlas is a platform that has information about all the longitudinal data set that we could identify across the world. At the moment, we have 2,662 as you can see in this little tab here. And I think it can be a valuable resource for early career researchers, or any kind of researchers actually, and not just researchers. I think it's a platform that can be useful for different stakeholders. But I think it's a useful platform, as it may be able to identify sources of data that could be valuable for your next project or your next paper. So the platform has information about those data sets. We do not hold any data per se. That would be too much of a job to kind of curate all this data. But we do provide information about about all these data sets. And usually we do give a 50-minute webinar, so I will kind of take you through the atlas, in the next 9 minutes that I have left. Given the interests of this group for dementia, I will kind of just use this as a topic for search. So what you can see here, the information about the different data set can be displayed in a map, or it can also kind of be presented in a view. But I think it's nice if you know where you want the location of your next data set to be. You can use this map as a starting point. You can see as well that we have filters here on the left-hand side to narrow down your search once you've identified a certain number of data set that could be relevant for your project. But let's say that you are doing something on, you have a project or your next run is about dementia. You can just type this this word in the bar here on top, and you can see that we narrowed down the number of data sets to 352 from around the world. Just looking at the map, you do have kind of valuable information there, because you can see that there is richness, but there's also some gaps. So there are lots of cohort data with measures of dementia, focus on dementia in Europe, in Australia and New Zealand. If I go down a bit, probably, yes, you do have a few data set here. And of course, North America is rich in those types of cohort, but you can see that there's quite a gap. Russia and the northern kind of territories there, but also in Africa. So these are kind of important gaps that we could identify just by looking at the map itself. But if you want to kind of identify data sets that could be useful for you, you have 352 that you can kind of explore, and maybe you don't have time to explore all those 352, but you could use filters that we have here on the left-hand side to kind of narrow down your search. For example, you may say that you want to have a data set with data on dementia, but also with mental health data, and also with neuroimaging data. And you can see that you've reduced the number by further by half. So you have 176 data sets from around the world that would have data on dementia, mental health data, and neuroimaging data. And because I'm Canadian, maybe I want to kind of just narrow it down to those data sets that are in Canada. You can see that those data sets appear here on the left. We have 4 data sets which are only based in Canada, and you have 5 that represents international collaboration. If I want to focus only on those based in Canada, I can click on this one, which is Sunnybrook Dementia Study. Click on it. That will bring me to the study page, where I have further information about the dataset itself, but also about the data it has collected through the years. So you can have, you can see here a selection of information about the sample, the age of the participants, the sex, whether it's representative at baseline. You also have sample features on the left-hand side. On the right-hand side, you have information about the data set, so where it's based, the primary institution. You also have useful links to the website when a study has a website, but also kind of a profile paper with their DOI. In this case, there's no kind of cohort profile papers. And then here you can see that you have the type of data that has been collected using some icons. If you go on the left-hand side, you can see the methods that were used to collect any type of data. And maybe worth to mention that we are mental health researchers, but those data sets are not focused only on mental health. It's about any topic. So you may have data sets that are focused only on cancer, only on heart disease, or only on socioeconomic factors. But because we have an interest on mental health, we did review all the data sets for mental health data here, and you can see that it will identify which measures have been collected. And very important as well, information about data access. And you can see here that this study is not so well documented because we could not find information about how to access data. Following one of the previous presentation, I just want to mention as well that we do indicate whether there's any engagement of people with lived experience as part of the study. So PPI engagement with the community, or engagement with the participants. And here we didn't have any. So let's go for another study. This one didn't seem to be so have so much information. But if I kind of click on this one, again, you have the same type of information. This one has a DOI for a cohort profile paper, which could be really interesting. And you can see as well that here there's information about how to access data. So there is a short summary about the data sharing policy. You have a link to take you directly to how to access the data, which is kind of super important. And you can see that this study has community engagement, which is valuable as well. You can see that that study as well has a clear focus on dementia, genetic predisposition, cognition, Alzheimer's disease, and it is part of a wider group of data set or a consortia. So that could be helpful for you. In interest of time, just want to make sure, and I will not have time to kind of go through that, but you can also select some information, some data sets, and you can compare. So if you click on those toggle here, you can compare the data sets on different features. These are pre-selected data sets, so they're not relevant to this, the ones that I just showed you. But just to show you that you can compare data sets, and you can see when there's similar features for each of the data sets here. And then just want to mention that this is a free platform. Yes, I have 2 minutes. This is free platform. So we are funded by the Wellcome Trust to come up with this platform. It is also constantly changing. So we are constantly updating the information that we have on the Atlas. So either we add new data set or we add new information. So we are currently going back to all those beautiful data sets that we have to add information about mental health measurements, so the instruments that were used to assess mental health conditions, also psychological factors and cognition, which could be kind of especially relevant for this group today. So we are in the process of doing that, and we hope to be able to release this new information for about 500 data sets in the summer. And then it will be kind of, we will keep on adding it. So the Atlas is constantly kind of changing and moving. When you do a search at a certain point, you can save it if you register to the Atlas. And then you can rerun it after a little while just to see whether there's new information that has been added. You can remove your filters here, and then you come back to the original platform. So I think that that is a very, very speedy tour of the Atlas. If you're interested in having a more kind of global or a more in-depth webinar, we can do that. I will stop sharing it. That's okay. You can do that by contacting us. We're happy to kind of provide a 50-minute webinar to groups who are interested to know more about the Atlas.
Thank you. Well done, Louise, for a very quick tour and demo. Very comprehensive. There are I can see questions in the chat. I wondered, just in the interest of time, maybe I'll pose this to you, Louise, but then we'll move on to our next speaker. And thank you again there. So there's a question saying, thanks for all the work on this site. It's a great resource. Filters for some data types like genetic data have always been blanked out, though. Will they be updated or activated at some point?
Genetic data? Sorry, I should look into the question.
Yeah, genetic data. Yeah, for the filters for some data types like genetic data have always been blanked out.
Absolutely. At the moment, we do not have, it is on our long list of things that we would want to add. There is one variable that we would be ready to kind of add to the atlas would be environmental measures. So, but it would require kind of a bit more funding, and genetic data, we would want to kind of do it. So at the moment, I think that we're seeking funding to kind of expand the information that we have on the atlas. But I think that I cannot provide a guarantee that we will have that anytime soon, but we are hoping to get more funding to do that.
Thank you, Louise. I know there's other questions coming up, but what we'll do just now is we'll pass across to InflAIM Project in Charlotte, and then we'll come back for a conversation at the end together. So, and thanks again, Louise. So if we could share the slides for Charlotte. Thank you.
Thanks, Kieran. And thanks for the talk before. I was just thinking that comparing the datasets feature looks really interesting. So thanks for that. I'll be looking at that. So thanks for inviting me along to talk at the event. So I'm going to start by briefly talking about our programme. So I'm Charlotte, and I'm a Senior Research Fellow on the InflAIM programme, which is using artificial intelligence to investigate links between inflammation, nutrition and health inequality in the development of multiple long-term conditions. Next slide, please. Next slide, please. Sorry. Okay, so InflAIM is a large NIHR-funded £4.8 million programme grant, and it's led by Professor Alex McGregor at the University of East Anglia, but it's in collaboration with a number of other institutions. So some of those include the London School of Hygiene, University of Exeter, University of Southampton, partners at UEA, the Citizens Academy, amongst others. And the duration of the project is 8 years, with some stop-goes along the way. Next slide, please. So I just wanted to start by briefly setting out the background to InflAIM. And as the title that I just mentioned states, the research is focused on multiple long-term conditions. So in the presentation, these are the acronym is MLTCs, and they're really a growing public health priority. And we define those as where a person has 2 or more conditions. So they could be physical or mental health conditions. And there's been a rapid rise in people having these 2 or more long-term conditions over the past 20 or so years. We also know that intermittent inflammation is an important process for survival during injury and infection, but actually chronic inflammation can lead to the development of long-term conditions like cancer and diabetes. So chronic low-grade inflammation can be a common biological mechanism that links these multiple long-term conditions together. We also know that dietary patterns and nutritional status can represent potentially modifiable influences on the development and the progression of these conditions, and that MLTC risk increases progressively with socioeconomic disadvantage. So InflAIM wants to understand how MLTCs emerge and then they accumulate. And so we need to use large longitudinal data sets so that we can model the disease trajectories and also look at how inflammation and nutritional exposures can contribute to inequalities in risk. Next slide, please. So as I've just mentioned, large observational data sets are really key to our research because they help us to carry out life course modelling, so capturing how these long-term conditions develop and accumulate over time. They allow us to reliably identify nutritional, inflammatory and MLTC exposure and outcome patterns, and also so that we can carry out trajectory analysis so that we can model sequences and the progression of the conditions, not just looking at single outcomes. They use real-world healthcare data, so that reflects routine clinical practice and population-level risk. And also we can do some inequality analysis, assessing the systematic differences by things like deprivation, ethnicity, sex and age, and then other variables when they're available with sufficient statistical power. And they provide scale for MLTC clustering so that we can identify stable and reproducible clusters of conditions across many of the different disease combinations. Next slide, please. So I've kind of touched on these anyway, but the aims and objectives of the programme is to develop and apply tools to analyse large-scale electronic health records, EHRs, and identify the life course clusters of the multiple long-term conditions. As I've said, we examine the roles of chronic inflammation, nutrition, and then malnutrition in MLTC development, and then quantify the risk, the variation in MLTC risk by age, sex, ethnicity, and socioeconomic background. And then it's moving on really to try and design and evaluate some kind of targeted interventions and policies that can prevent the onset of MLTC, but also the progression of those conditions. So the aim is to develop and implement something like a primary care-based intervention or public health intervention, like risk alerts, lifestyle, or pharmaceutical strategies. Next slide, please. So this just sort of sets out the kind of timeline of the programme. So at the moment, we're in phase 1, which is the analytical phase, years 1 to 3. We're about 2/3 of the way through that phase. And I'll talk a bit about what we've been doing within that. And then we move into phase 2 in years 3 to 4, which is the intervention development. And then finally, hopefully into phase 3, where we roll out the intervention in years 4 to 8. Next slide, please. I've just realised this is one of those slides where I would press and things would add on, so it's not going to work very well. So I'll just, anyway, is there any way you can add the bits on? If not, we'll just go on to the next. Oh, that's it. And there probably is another bit. But so a key part of the first early stages of our programme was to identify which of the longitudinal data sets we needed to use. And there are 7 core ones for InflAIM, and these are those. So I'll just talk about them on the next slide. So next slide, please. I'll talk about 2 of them in more detail a bit further on, but so these are the top ones. The top rows are the 7 core data sets that we are using. So there's UK Biobank, the Clinical Practice Research Datalink CPRD, a local Norfolk Arthritis Register NOAR, which is a smaller data set which has got about 5,000 records and is not publicly available, but you can access by applying for it. The European Prospective Investigation into Cancer and Nutrition, which is EPIC Europe. Again, it's got about 500,000 patients or participant records, but again, you need to apply to have access to it. A privately held data set called Evergreen Life, and the English Longitudinal Study of Aging, ELSA, which I think was mentioned in one of the presentations earlier, and also NHANES, which is the National Health and Nutrition Examination Survey, and those 2 are both publicly available. Beyond the 7 core data sets, there are other international data sets which we wanted to get access to in order for us to make cross-country comparisons. And so far, we've identified and accessed the Chinese Health and Nutrition Survey, Health and Aging in Africa, so that's HALSA, LASI Longitudinal Study of India, Brazilian Longitudinal Study of Aging, and then a few others. One of those there is a subscription-based commercial database. Next slide, please. So I just want to focus briefly on 2 of the primary data sources that we've been using. So the first is UK Biobank, which has about 500,000 participants, and they're recruited from 2006 to 2010 when they're aged 40 to 69. It's a really useful data set because it's got rich baseline measures and biomarkers that you can then link with health outcomes. So that's really useful for studying biological and lifestyle risk factors, and also, which is important for us as our programme, inflammation. CPRD, so the Community Practice Research Data Link, uses UK primary care electronic health records that are curated for research. So it's getting routine GP data at scale. So there's millions of records, 18 million records. And that's got information on diagnoses, symptoms, prescriptions, referrals, and tests. And the really useful thing also is that you can link it to other data sets to capture outcomes. So it's linkable to hospital episode statistics, so admitted patient care, emergency care, outpatients diagnostics. It's also linkable to the cancer registry, ONS death records, and other things like pregnancy records. You do have to pay for the dataset initially and also for additional linked datasets, and it's quite expensive. And the same for UK Biobank, you have to pay for that as well. And I'll talk about access issues in a bit. Next slide, please. I'll just discuss now what we needed to do once we got the datasets was to develop a list of multiple long-term conditions that we were going to use for our programme. So in order to do this, we integrated evidence from 8 established MLT sources, and then we went through and refined it with direct clinical and patient input. So that gave us a list of 363 candidate conditions, which we refined and then got down to 60 validated multiple long-term conditions, which is the list that we're using for the InflAIM programme. We then needed to harmonise some code lists for those conditions across READ version 2, SNOMED CT and MED codes. And that gave us 7,426 validated codes, which we then needed to map to ICD-10 chapters. And that's in order to be able to use the codes that are in the data set. So for example, in CPRD, and then Biobank uses ICD-10 codes, and we need it for other comparisons. We then needed to look at working out which ones of our multiple long-term conditions had an inflammation focus, which there are 17. And then also we produced additional autoimmune and infection code lists. And this whole process is set out in a paper, which is documented on the slide. And also the code lists are available on our GitHub repository. Next slide, please. So because our focus is on inflammation and nutrition as well, we needed to operationalise that. So we've developed a list of inflammatory exposures and proxy measures on subclinical inflammation. We've also mapped medications to conditions, are developing an inflammatory drug list, and are looking at determining dietary exposures, including dietary patterns like the Dietary Inflammatory Index and the Mediterranean diet, and nutritional exposures and bioactives. And we're looking at identifying measures of inequality as well. So we've been building an inventory of available variables across all those different data sets that we're using. Next slide, please. Data processing and access issues is massive, obviously, that other people have talked about as well. I think Emma discussed that in her presentation. But in terms of data access and governance, there are really complex approval processes in getting access to some of these data sets. There's data sharing agreements and things like secure research environments. So the other thing to say is there's variation in the governance frameworks across the different data sets. So it's not a one size fits all for each, you've got one and you can use that for all of those data sets. There are issues around security and storage. So large scale health data needs analytics to be carried out within secure environments, which I think Emma did talk about, these trusted research environments. They've got restricted export functions and constrained software access. And that really does have an impact on analytic workflows and collaborations. Obviously, also, there are large data sets, particularly CPRD, with millions of observations at the patient level, and this can really affect your processing time, server capacity influence, and therefore modelling strategy and analytic feasibility. Once you've got the data, obviously, there's issues around missing data. So there could be systematic and differential missingness, for example, with laboratory biomarkers and dietary measures particularly, and these need to be addressed really carefully because you need to minimise bias in order to ensure valid inference. And then, as I talked about a bit earlier, there's harmonisation across data sets, but not just in terms of the coding, also in differences in terms of variable definitions and the timing of the measurements that are taken, for example, measurements in biomarkers or also in nutritional data. And that requires rigorous alignment in order to be able to make comparability and reproducibility. And then finally, in terms of the representativeness of the data sets, there could be selection bias, and differential participation can limit the population representativeness. Next slide, please. Just briefly, just talking about our analytical strategy. So we've been doing unsupervised trajectory clustering, survival modelling, some risk prediction, individual multiple long-term condition forecasting, and then also cross-validation, external validation. And then we'll be looking at explainability, so interpretability of the modelling of drivers and interactions. Next slide, please. So just briefly, again, to go back to that, we're in phase 1 at the analytical stage at the moment, but starting to move towards the end of towards next year to phase 2. So looking at our intervention development built on what we found out in phase 1, and then finally to phase 3, looking at actually carrying out the intervention. Next slide, please. So I just wanted to finish really by talking about our methodological learning so far, and really it's just that alignment of the definitions and the coding systems and exposure measures across the data sets is really, really resource intensive. I mean, I guess we knew it was going to take a long time, but it really does. Phenotype definitions really do require rigorous validation. So if there's misclassification, it could introduce systematic bias into your analyses. There are issues around selection bias, missingness, and coding differences, and they really do need to be evaluated before you apply any statistical or machine learning approaches. And then finally, really that version controlled and shared phenotype libraries and transparent documentation is really crucial. And we're trying to do that through our GitHub page as well as obviously publication. Next slide, please. And that's it really. Thanks for listening. And I didn't know if there probably isn't time for questions, but if there is any questions, thank you.
Thank you very much, Charlotte. I think what we'll do, just in the interest of time, is go straight on to the next speaker and then hopefully catch questions in the Q&A, pass them across to you and keep that kind of conversation going. I guess it starts today and continues on further, I'm sure. Our next talk here is on the PROTECT database, and Anne Corbett is here to join us to talk us through that. So I'll pass across to you. Thank you.
Good morning. Thanks very much. I'm actually going to pass to my PROTECT project manager, Megan, if she's able to unmute, and she's going to present on our behalf. Are you there, Megan? Possibly not. Maybe she doesn't have the right access. Okay, in which case I will start talking and hopefully she'll be able to join us. Okay, so morning everyone, lovely to be here and talk about our PROTECT study. Many of you hopefully will have heard of PROTECT before. It's a longitudinal study of healthy aging funded by NIHR and a matrix of other funders here at the University of Exeter. It's an online cohort study which has allowed us to really scale up this approach to data collection because of course people can take part from home and that makes it far more cost efficient than bringing people into the clinic. It has allowed us to introduce new mechanisms to sort of recruit and retain people in the cohort, and therefore we have large numbers. We also run things like clinical trials and additional nested studies in the cohort, and more recently we've started to look at biomarker research as well. Importantly, PROTECT has full consent for recontact, so we can reach out and invite people to take part in additional research. Next slide, please. Oh, there's a slide missing. That's fine. Was there another one? No? Okay, no worries. Let me just check what we were expecting to say there. Just a moment. Okay, so just a little bit more information before I launch into any of the characteristic stuff. So PROTECT's been running for, well, we're now in our 12th year. So we launched in 2014. We target adults aged 40 and above, originally 50, now 40 and above. We have a target of 50,000 individuals for this study. We've just got just under 30,000 active participants at the moment. The goal of PROTECT is to explore cognitive health. So we have a particular interest in sort of dementia prevention, in early detection, in understanding risk factors for dementia and understanding sort of cognitive trajectories and the factors that influence that process. So this gives you a sort of snapshot of how the cohort looks at the moment. You can see we've got really nice national spread, given that we're based in Exeter. No surprise that we have a slightly larger contingent of participants in the southwest, but we do have representation across the UK. You can see we've got a decent spread across our age range with a sort of peak in the 60s to 80s, which is fantastic. These people are kind of aging with us. So we've got a lot of individuals in that kind of early dementia risk profile. A slight bias towards females, slight bias towards sort of more highly educated, and not going to hide, we do have a real bias towards white in our ethnicity profile. We are working really hard on this at the moment. We've got a particularly focused diversity drive at the moment to try to level some of this out and make sure we are a representative cohort. Next slide, please. Thank you. So each participant comes back to our web-based platform every year. They all have their own dashboard on the website. It's really nice and engaging. They can do things like brain training games, but at the very minimum, they are asked to come back every year and do a series of assessments. And the core of these assessments is our computerized cognitive test battery, which is called the PROTECT battery. And this takes about 30 minutes. They do it each year. The battery that we have in PROTECT has been really extensively validated now because we have been running for 12 years, and it builds on established paradigms for cognitive assessment as well. So the PROTECT battery has really robust sensitivity to cognitive status, to functional status, and also to change, including preclinical change, far more sensitive than you would expect from a sort of an in-clinic assessment. So it's particularly good for early cognitive impairment states. It's validated for unsupervised use at home. People really enjoy using it. We get very high quality data and very low missingness, which is fantastic. And more recently, we've shown really robust correlation with AD biomarkers as well through some of our biomarker work. So you can see some of the sort of distributions there on the right. Sorry, we do have much better data visualizations, which we're working on at the moment. They just didn't quite make it into our slides this time. But we captured the domains listed there. So executive function through verbal reasoning and trails, attentional measures using reaction time and accuracy measures like simple reaction time, digit vigilance, etc. Episodic memory through delayed picture recognition tasks, and a series of working memory tasks as well. So it's a really comprehensive battery. Next slide, please. Thank you. Oh, I should have mentioned that those cognitive tests obviously stand alone, but we also create composite and global measures of cognition, which are very informative when we're considering trajectories. So our participants also complete a series of non-cognitive assessments. This is all self-reports, of course, which we found to be a very effective way of gathering large amounts of data from these individuals. And this is a list of some of the data that we collect. So obviously we collect their demographics, including their location, because we communicate with them in that way. We collect their medical history, including key medical risk factors, both from the Lancet Commission and broader. We collect mental health through the PHQ-9 and GAD-7, as well as other aspects of mental health like trauma. We have a very extensive lifestyle questionnaire that captures, again, the sort of risk factors that you would expect from the Lancet Commission, but also some more exploratory ones. And this is a really broad questionnaire with a lot of opportunity for novel research questions to be asked. We have the mild behavioural impairment inventory in PROTECT, which we have validated through PROTECT and shows some very interesting data around sort of pre-psychosis and early behavioural symptoms that I think are very exciting, actually, for early dementia detection. We capture function through activities of daily living and the IQ code, and we capture family history, as well as a whole series of optional questionnaires that participants can choose to give us more information on, including neurodiversity, physical fitness, brain trauma, quality of life, etc. Next slide, please. Thank you. So every participant in the cohort is also sent a DNA sample in the post using saliva sampling. We have, obviously, because this is a slightly more manual process, we have a slight lag here. So we've got about 10,000 of our participants fully genotyped with GWAS data. The rest are on the way. This process has been really effective, actually, and almost everyone is happy to provide this sample. So we've got this building data set, which has been very valuable. The genotyping is done using the Illumina array and imputed here at Exeter. You've just got a quick snapshot of our E4 genotype profiles there. I think sort of most interestingly, we have over 200 E4 individuals in the cohort who are obviously of particular interest. And we also have full polygenic risk scores for all of these individuals as well. Next slide, please. So PROTECT is, of course, our research baby, but it's also available as a resource for research for third parties. So there you can request data from us, and that can include any of our cognitive data, any of the questionnaire data that we capture, and also our genetic data. We also have a process whereby you can access the cohort themselves for research that you would like to run. And that is we will then support recruitment through the cohort using the consent for recontact mechanism. That can be either cohort wide, or we can pre-screen the cohort for you and send you, if you like, signpost to you participants who may be eligible for a study that you're running. We also run what we call nested studies, whereby we actually deliver your research for you. So that can be anything from a one-off questionnaire on the platform to answer a particular research question, through to novel biomarker validation, through to clinical trials. And we've actually built a really effective model for remote and hybrid trials on PROTECT. I'm particularly proud of this. We can recruit very swiftly, get very high data quality, and people really enjoy doing remote trials on the platform. Next slide, please. Thank you. So this is the bit I was hoping Megan might present, but I'm assuming her
I'm here now.
Oh, you are there. Oh, wonderful.
Yeah,
Megan,
I was just
please do take on the next two slides, because this is very much your
Okay, great. Yeah, so we have a process in place to allow researchers to access our data or perhaps the cohort. First protocol is to contact us at protect.data@ExeterAC UK. We ask you to complete an initial request form just to register what you're interested in, and we then send you a full specification form for you to complete. This is then reviewed by the committee, and then if approval is granted, we get data sharing or cohort sharing agreements in place. And then we share data via a SharePoint site that's secure between the researchers and us, or we go ahead and plan the recruitment to your study. I'll put a link into the chat for the initial request form, so that will just save you a step. And that is usually quite a swift operation that we've got going there. Next slide, please. And this is just an example of other collaborative projects that we've had with researchers. The wide scope of data that we collect allows for some not necessarily pure cognitive related research. And so some of these are looking at the autism spectrum traits and memory, or depression symptoms linked to Alzheimer's disease. We've had research with sports-related concussion and TBI, as well as examination of apathy and depression in cognitively normal adults. And we also, this last one is more of a clinical trial looking at the oral microbiome and biomarkers in older people with MCI, looking at their APOE4 genotype. So you can really use our data to explore lots of different research questions, really. Next slide. And these are just the links to how to contact us and how to request data. I'll put that link in the chat. And thank you for your time.
Thank you very much, Megan and Anne, there for the presentation on Protect. What I'll do is, because we're just about coming up to time here, fantastic array of speakers, lots of data sets, hopefully lots of opportunity for everyone to explore these data sets, through SPIN-D or even beyond. Perhaps we could pass across to David and Georgina for some reflections, discussion here at the end, bringing the session to a close. Perhaps to Georgina first. I think we're going to have a look at some of the comments and in the Q&A and come back on those.
Yes, thank you. Thanks, Kieran. And yes, we will. We'll make sure that we've had a look at all of those Q&A and chats, and we'll look to carry on. There'll be the recording and an ongoing discussion, as I understand it, that we can have on the dementia researcher. I just want to say hello to Dahi, who's very kindly sort of joined today, and I know has been enthusiastically engaging in the chat and the Q&A. And I can see is very keen to reach out to various of you that have been speaking today. So do have a little look out there for Dahi's contact. And I thought maybe I noticed that one of the things that Dahi asked right at the very beginning, Dahi, somebody's always pushing us to keep progressing and not stand still, and had raised a question at the beginning about the extent to which any of the databases would be able to involve people from LGBTQIA+ communities. So I don't know whether anybody has any immediate comments on that, or whether that's something that we need to add in sort of text in the chat later. Any comment from anyone from the databases? If not, then what I'll do is hand over to David for a few concluding words.
I think Anne's got a quick comment.
Ooh, Anne.
Yep, very briefly. Thanks, Georgina. Hi, Dahi. Lovely to meet you. We have an ambassador group on Protect, which is our own sort of PPIE group. We would welcome individuals, particularly when we've got such a drive towards diversity and broadening the scope of what we do. So please do get in touch, and we'd be delighted to speak to you. I'll pass over now. I feel like I'm
Thank you. Thanks. Thanks, Anne. Yeah, we'll pass across to David for some concluding remarks. And thank you, everyone, for all the contributions throughout. David, the floor is yours. Thank you.
Thank you, Kieran. We're at time, so I'll keep it very brief. But just to reflect on what we've seen today, clearly the resources that we have available to us to do amazing science are better than ever. And I think this is a real opportunity, but it's also an enormous challenge. So there are great opportunities to learn from each other and to accelerate things. There's a huge barrier to analysing some of these data sets, but where other people have already done it, we need to be talking to each other. So just to say that we need to be collaborative. There are funding opportunities through SPIND, but a range of other funders, including UK government grants and charitable grants and so on. So let's keep those conversations going. SPIND acts as a catalyst and a funder for that kind of activity. And we have amazing people. The turnout today has been very good. Thank you everyone for your questions, and apologies that we're not able to address all of those today, but as Georgina said, we'll follow up on those and we'll keep the momentum going. So I'll stop there for the sake of time, but thank you again to everyone for joining.
Okay, so we'll close the meeting there. Thank you, everyone. Have a nice rest of the day, and thanks for all the contributions.